question. So our learning objectives for today will be definition and classification of impacted third molars, radiographic assessment, assessment of difficulty of removal, surgical technique of removal, mucoperiosteal flap and its complications. So the definition to start with is the impacted tooth is a tooth which is partially unerupted, is positioned against another tooth, bone or soft tissue so that its further eruption is unlikely and described according to its anatomic position. So if we classify it, it is classified on in three types. The first is based on overlying tissue, second Winter's classification, and third is the Pell and Gregory's classification. So the first one is based on overlying soft tissue. So first, it is again divided into two parts, soft tissue impaction and hard tissue impaction. Now, soft tissue impaction, there is presence of dense fibrous tissue overlying the teeth, sometimes preventing it from normal eruption. So this is frequently seen in cases of central incisors in which early loss of primary teeth with subsequent masticatory trauma to the ridge results in fibrosis. And hard tissue impaction, here the teeth fail to erupt due to obstruction caused by overlying bone. When the soft tissue flap is reflected, here the tooth is not visible. An extensive amount of bone must be removed and tooth may require sectioning before removal. The second type of classification is the Winter's classification. Now this is based on the inclination of the impacted molar to the long axis of the second molar, Now this is the most commonly used classification. It is divided into 6 types: mesioangular, distoangular, horizontal, vertical, buccalolingual, and transverse. And the third is the Pell and Gregory's classification. It is again based on 3 subtypes. One, the anterior border of the mandible, relationship with the anterior border of mandible, the amount of bone covering the impacted tooth, and the long axis of impacted tooth. Now the third one, the long axis of impacted tooth, it is same as the Winter's classification. But the first one is the relationship with the anterior border of ramus. It is again divided into 3 classes, class 1, 2, and 3. The class 1, now here, the anterior-posterior diameter of the tooth is equal to the space between the anterior border of ramus and the distal surface of the second molar. In class 2, the mesiodistal diameter of the tooth is greater than the space available. And in class 3, the tooth is completely within the ramus of the mandible. Now, as you can see in the diagram here, the first 3 diagrams are of class 1, the bottom 3 are class 2, and the diagram on the right is class 3. As you can see in the top 3 diagrams, the mesiodistal or the anterior-posterior diameter is equal to the space between the anterior border of ramus and the distal surface of the second molar. In the bottom 3 diagrams, you can see the mesiodistal diameter is greater than the space available. And in the third diagram, you can see it is completely embedded into the mandible. Now, according to the amount of bone covering the impacted tooth and the relationship to the occlusal plane, it is classified as position A, B, and C. Position A, the level of the occlusal plane is same as the second molar. In position B, it is midway between the cervical line and occlusal plane of the second molar. And in position C, the occlusal plane is below the cervical line of the second molar. Now, as you can see here, position A, position B, and position C, it is the same level. It is in between the cervical line and the occlusal plane, and it is below the cervical line in the third diagram. Now, this is the diagram which you can draw in the exam. It is a line diagram. It is simplified. It is Pell and Gregory's classification. Now, this is a flow chart which you can again draw in the exam. It is a simplified classification, and flow charts are generally easy to understand. So these are again based on 3 types and its subtypes. Now, radiographic assessment is again an important aspect. Here, the types of radiographs used are IOPA, bite-wing radiograph, occlusal, lateral oblique, OPG, and CBCT. Now, war lines is again an important SAQ, which can also be asked as MCQs. War lines is WAR, white, amber, and red lines. Now, firstly, the white line. The line is drawn from the occlusal surface of the erupted mandibular molars and extended over to the third molar posteriorly. Axial inclination is seen here. Now, the occlusal surface of vertically impacted third molar is parallel to the white line. As you can see in the diagram on the right, the occlusal surface of third molar with distoangular impaction meets the white line in front of the third molar, and occlusal surface of the third molar with mesioangular impaction meets the white line behind the third molar. The occlusal surface of horizontally impacted teeth meets the white line in a perpendicular direction. Now, what this white line indicates is the depth and the relationship of the occlusal surface of the impacted molar. The second is the amber line. The amber line is drawn from the surface of the bone on the distal aspect of the third molar to the crest of the interdental septum between the first and second mandibular molars, as you can see on the diagram on the right. This line represents the margin of alveolar bone covering the third molar. So we know how much bone is covering the third molar here. And lastly, the red line. The red line is an imaginary line drawn from the perpendicular from the amber line to an imaginary point of application of elevator. So it is a perpendicular line from the amber line. Usually this point is the CEJ on the mesial surface of the impacted tooth, except if it is distoangularly impacted, the point of application will be on the distal aspect. The red line here indicates the depth of the impacted tooth. Now, with each increase in length of red line, the impaction becomes more difficult to remove. Now, this is a line diagram of the wall lines, which can be again drawn in the exam, simplified. Now, assessment of difficulty removal is done according to WHARFE's classification. Now, WHARFE. W is Winter's classification, H is height of mandible, A is angulation of second molar, R is root shape and development, F is follicles, and E is path of exit. You can see it in the diagram below. Then the Pederson scale, it is a modification of the Pell and Gregory scale. Here it is classified according to 4 types: the spatial relationship, the depth, Ramus relationship, and difficulty index. It is given values 1, 2, 3, 4 respectively, as you can see in the table. The difficulty index, the bottom part of the table, is very important. Now, if it is very difficult to remove it, the value will be between 7 to 10. If it is moderately difficult, it will be 5 to 6, and if it is slightly difficult, it will be 3 to 4. Now, the surgical removal of impacted third molar, here this is just a point wise. I've jotted down the points where you can just write it at the start of your answer. It is asepsis or isolation, local anesthesia or general anesthesia, incision flap design, reflection of mucoperiosteal flap, bone removal, sectioning or division of tooth, elevation and tooth removal, debridement and smoothing of bone, and closure or suturing. Now, this procedure depends on type and degree of impaction, soft tissue exposure, amount and technique of bone removal, and odontectomy. This is an important term. It is dividing the tooth prior to the removal. Now, it will be explained in steps. Now, as follow the diagrams that are given below. Step 1 is the clinical assessment of impacted tooth. Step 2 is radiographic assessment. Step 3 is pictorial representation of the Ward's incision. Now you can see the line diagram of the Ward's incision on the right. So what is the modified Ward's incision? In the modified Ward's incision, the anterior incision is commenced at the distobuccal corner of the mandibular first molar instead of the second molar. In the Ward's incision, it is the second molar, distal aspect of the second molar. In the modified Ward's incision, it is commenced at the distal aspect of mandibular first molar. Now, as we continue with the steps in surgical removal, step 4 is firstly anterior release incision is made, including interdental papilla at 45 degrees to the second molar. And secondly, crevicular incision or internal bevel incision is done, which removes the sulcular epithelium. Then third, the distal release incision at distobuccal line angle is done to avoid injury to the lingual nerve. Step 5, the buccal mucoperiosteal flap is raised. The buccal mucoperiosteal flap, including interdental papilla, is raised in the second diagram. And the third diagram, complete elevation of flap, is done to expose the impacted tooth with Austin's retractor over the external oblique ridge. Step 6 is raising of lingual mucoperiosteal flap and complete exposure of the impacted tooth and surrounding bone as shown below. Step 7 is guttering of the mesial, buccal, and distal bone closest to the tooth. Step 8, initiation of odontectomy, that is dividing the tooth along the long axis of the tooth midway at bifurcation. and orentectomy is done until 2/3 of the buccolingual width using rotary instrument. Now, completion of the orentectomy is done using a straight elevator. For that, the working end of the elevator is engaged into the created groove and rotated clockwise. Step 10 is remove the distal segment. Step 11, remove the mesial segment using a mesial point elevator. Step 12 is extraoral reorientation of the extracted tooth fragments and confirmation of complete tooth extraction. So extraoral reorientation is done to see that the complete tooth is extracted and there are no fragments remaining inside. Step 13 is wound debridement and primary closure. Now, mucoperiosteal flap, there are 3 different types. You can see in the diagrams on the right. Envelope flap, first one. Second is the L-shaped flap. Third, bayonet flap. And D is the trapezoidal flap. Now, ideal requirements is that adequate exposure of tooth should be there. The base of the flap should be wide for adequate blood supply. It should avoid soft tissue trauma. If flap extends distobuccally, it can cause postoperative trismus or herniation of buccal pad fat. The flap should primarily close over solid bone. Incision should not damage any vital structures. Other techniques of fluorobonal removal are the lateral trephination, which is also known as the Henry's abortion technique. It includes removing any partially formed and unerupted third molar in the age 9 to 12 years. Here, the bone healing is excellent without loss of alveolar bone around the third molar. Then the lingual split technique is also known as William Kelsey-Frye technique. It takes advantage of thinness of the lingual cortical plate to remove the lingually impacted molar. And third is the Moore-Gilbert collar technique or the chisel technique. The removal of bone with burr, rosehead number 3, by creating a gutter around the neck of the infected bone. The bone must be removed to expose the entire crown till the CEJ. Now, complications are intraoperative and postoperative. Intraoperative, there might be fracture of the tuberosity, dislodgement of the tooth into the maxillary antrum, dislodgement of tooth into the soft tissues, damage to adjacent second molar, and postoperative complications can be infection, dry socket, or oroantral fistula. Now, this is a short video of the surgical removal. So this is the presentation about impaction of mandibular third molars. I am Rucha Shilke, and this presentation is guided by Dr. Bhushan sir.